Good morning, everybody. A warm welcome to the City of Joy. I, Dr. Nandini Sinara, on behalf of the Society of Pediatric Intensive Care, Kolkata, take great pleasure in welcoming you all to the East Zone Pediatric Critical Care Conference 2023. Hope you had a comfortable journey and are enjoying your stay here. We had 5 workshops yesterday on basic ventilation, advanced ventilation, ECMO, point of care ultrasound, and nursing workshop. We had a great successful participation and with great enthusiasm from the participants and also from the faculties. So today we will be starting our morning session with PG case presentations. The judges for this session are Dr. Jaisal Seth. She is a senior consultant pediatric intensivist, neonatologist and pediatrician from Fortis Hospital, Mumbai. She is attached there from 2011. I'd like to welcome you, ma'am, to the stage. I'd also like to welcome Dr. Bandhya Sahu. She is the professor and pediatric intensivist in the Department of Pediatrics, Kalinga Institute of Medical Sciences. Please, ma'am, come up to the stage and take your seat. I'd like to welcome Dr. Koel Sana. She's a second year PGT in Medical College, Kolkata. She is going to present her oral paper. Please come up. Thank you.
A very good morning, judges and all present here. I am Dr. Koel Sana, Junior Resident, Department of Pediatrics, Medical College, Kolkata. Today I am here to present my case study on comparison of neurological outcome of clinical versus clinical and near-infrared spectroscopy guided management of acute encephalitis syndrome. Non-invasive monitoring of regional cerebral oxygen saturation carried out by near-infrared spectroscopy technique has shown to be reliable surrogate marker of cerebral perfusion, which can be an observer-independent measures of tissue hypoxia. There are many studies regarding role of NIRS in neonatal HIE, traumatic brain injury, cardiac and non-cardiac surgery, but there is almost no study regarding role of NIRS on acute encephalitis syndrome. Now, what is this NIRS? This is non-invasive continuous tissue oxygenation monitoring. It measures oxygen saturation from the ratio of different optical absorption coefficient of infrared light by oxy and deoxyhemoglobin. It uses Beard-Lambert equation. Cerebral RSO2 cutoff of less than 55 considered decreased cerebral oxygenation, and persistent follow-up RSO2 less than 55 for more than 5 minutes is threshold for intervention. This is NIRS monitoring, and these 2 probes are placed on the forehead of the child, and there is in this probe there is a light source which emits infrared light, and there are chromophores like oxyhemoglobin, deoxyhemoglobin in blood. They absorb the infrared light and reflects, and this reflection is detected by detector present in the probe. AES, one of the complication of AES is raised intracranial tension. So management and prevention of developing raised intracranial pressure remains the vital for management of better neurodevelopment outcome. And cerebral perfusion pressure is the surrogate for cerebral blood flow and oxygenation. Cerebral perfusion pressure can be expressed as mean arterial pressure minus intracranial pressure. So CPP is indirectly proportional to intracranial pressure. So intracranial pressure if rise, if CPP decrease. There are 2 ways of monitoring intracranial pressure, like invasive technique and non-invasive technique. Though invasive technique is gold standard, it comes with so many drawbacks. And amongst non-invasive techniques, there are transcranial Doppler and NIRS. Transcranial Doppler is observer dependent. This is non-continuous and expertization is needed. But on the other hand, NIRS is continuous process, observer independent, and no expertization is needed. Objectives of my studies is to compare the Glasgow outcome scale in children with acute encephalitis syndrome treated according to clinical assessment only and versus clinical along with NIRS monitoring. Now the methodology. Ethical clearance was taken and there was no previous studies regarding role of NIRS in AES, so we went for a pilot study. From the month of May 22 to May 23, all the children aged 3 months to 12 years of age admitted in PICU with AES were taken into our studies. A proportion of patients put on NIRS monitor as per clinician's discretion and availability. RSO2 value of less than 55% were considered as intervention threshold and another proportion of patients were monitored clinically only. At the end, Glasgow outcome scale at discharge along with length of PICU stay, hospital stay, 28 days ventilator free days were compared. Glasgow outcome scale. If death occurs, we give a score of 1. Persistent vegetative state, a score of 2. Severe disability 3, moderate disability 4, good recovery is given a score of 5. Children with 3 months to 12 years of age were with AES included in our study. Children with traumatic brain injury, space occupying lesion of brain, children with structural brain defect and who died within 24 hours of admission were excluded from our studies. And those patients were previously included and later found to have chronic meningitis were excluded later in our studies. Statistical analysis has been carried out via SPSS version 23 software package. Now coming to the results. Demographic and clinical parameters, distribution of age, sex almost same in 2 groups, and signs, symptoms, vital parameters, IBG parameters and other organ involvement, there shows no significant statistical difference. Even the treatment, respiratory support, there is no statistical difference between 2 groups. Lab investigation and imaging, also there is no significant difference between 2 groups. And the outcome parameters, it also shows there is no significant difference in 2 groups, but mean Glasgow outcome score is little higher in clinical with NIRS than clinical only group, and odds of severe disability is lesser in clinical with NIRS group. Now coming to discussion, systematic review with meta-analysis of previous studies found no evidence supporting the benefit of cerebral NIRS monitoring in neonatal intensive care, cardiopulmonary bypass surgery or various surgeries in both clinical and adults. In our study, though there is no significant difference in outcome of clinical and NIRS guided management over only clinical of management of AES, but mean Glasgow outcome score is higher in clinical and NIRS group than only clinical group, and odds of severe disability was lower in clinical and NIRS group than clinical only group. Coming to conclusion, though there is statistically insignificant difference between outcome of 2 groups, we cannot completely disregard NIRS and non-invasive monitoring tool. We need further evaluation with larger sample size in future. Our study has its limitations also. Since NIRS is not gold standard technique, it reflects only the cerebral blood oxygenation in part of frontal lobe, not the whole cortex. It is independent on oxygen saturation and oxygen extraction fraction, and it may fluctuate with mental activation in alert patient. Thank you.
Can you please tell, was there any specific reason why you took children up to 12 years?
Generally in pediatrics.
Older children?
Sorry ma'am. In pediatrics group we generally in our college, in our hospital, we generally see children till 12 years of age in our hospital, in pediatrics department.
Hospital policy, only up to 12 years you are taking. And what about that, did you have any comparison about the severity of the illness in these patients?
Can you explain a little bit about this Glasgow scale? Is it same for the verbal and non-verbal children?
Same for?
Verbal and non-verbal children, because that was your intervention, right? So is it same? Because for GCS we use modified and non-modified, the normal GCS. So for the, because you have 3 months to 12 years of the age. So this Glasgow Gloma scale is validated for all the age groups?
All the age group.
Okay. And you mentioned in one of your slides that the Glasgow Coma scale was higher in the clinical group compared to. Can you go back to that slide? Because you went very fast and it says some new kind of the thing. So. And did you use the fixed criteria to define, because you are studying encephalitis, right? So did you have a fixed criteria to define encephalitis? Was it based on what? If you can just slide the, first is your patient population, not this, little, we can go directly to the methodology. So this is understood. Here you did not randomize, you just went as per the observational study. Now the next. So I was asking about this, is it validated for all the age groups in children?
Yes, ma'am.
This is a Glasgow, okay. You have not put any reference over there. Okay, next. So you said all your inclusion criteria, patient population in PICO, children with 3 months to 12 years of the age with the diagnosis of acute encephalitis syndrome. So did you have any definition how to define acute encephalitis syndrome? That was based on what parameters did you use?
Fever at any time of the year, of any duration, and with following features like altered mental status like delirium, seizure, coma, and new onset seizure, excluding febrile seizure.
Okay. So that was only clinical definition, not the neuroimaging or the biochemistry, right?
No.
Okay, if we go further to that slide. So in the results, move on, keep moving on. Aage, little more. Now, why did you, here you have written treatment and respiratory support. So what you were actually aiming to study? You have taken those as your variables, treatment and respiratory support. So here, like how does, what I'm failing to understand is, what it has to do with the needs, what are you trying to correlate? What was your hypothesis?
Actually, Glasgow outcome scale, what is the outcome, and also we measured how many PICU stay and ventilator free days also, we compared.
But what is the correlation of the needs with the respiratory support? It just you collected the data as a part of your spectrum. No. Okay. All right. If you can go to next. Next. So here you said your mean Glasgow outcome score was more in the
Clinical
group, your intervention group compared to your clinical group, and here the severe disability was less versus this. So what is the inference? What did you come to? What was the correlation in this? What was the correlation? Because there's no statistical significance. What was the correlation?
It signifies the clinical, if you, NIRS is as, if used as adjunct to clinical monitoring, it is better, outcome is little better. Though there is no significance, but severity is, it is shown, severity is little less in clinical with NIRS group.
Just because here we are studying role of the NIRS. So what outcome you were looking for, which is what I am not able to understand.
When children are getting this how well neurologically are they at the time of discharge? That is their aim.
Thank you.
Good job.
Just I want to know one thing. Nice presentation. You have included the groups from 3 months to 12 years. Madam already had mentioned that matter. There are some studies on needs on newborn on HIE. So why you have excluded the initial part of the, 1 month to 3 months? Because they have, there are some studies, you have a validated data from the newborn. So why you have excluded from your study these groups, 1 month to 3 months?
Because the presentation is different.
You did not even mention the Glasgow Coma scale properly, because it is not same for the all age groups, and that is definitely a bias. And apart from those bias, there are several bias in your study also, because it depends upon the that you have measured the what you have measured by NIRS.
Cerebral oxygenation.
So when you are measuring, there are so many factors. You can alter the saturation or the curve, support like blood pressure of the baby, or what the amount of oxygen you are giving. So had you mentioned in your study about the parameters?
No,
Because you are reflecting the cerebral blood flow saturation. So you have so many bias factors. So you have to mention in your study. So you only mention that meningitis you have excluded, and brain injuries you have excluded, but other parameters you have to include in your study also. And what do you want to say from this study? I want to.
That is not clear.
That is not clear actually, because you have mentioned some parameters that is showing some good signs. At the end, you are showing there is no difference between the two groups. So what do you want to show from this study? What is the message you are going to deliver to the audience?
So we need more studies with larger sample size. Since this is a pilot study, sample size was less. So if we go for further studies with larger sample size, maybe the results may be different, would have been different.
Just I'll quickly summarize, just to make it simple. It's a very good attempt that you are here. We took many years to be, able to present, so it's a very good attempt. But just look at it as a PICO. So a patient population is basically all acute encephalitic syndrome, which is a clinical definition. Your intervention is applying NIRS, right? And because that is what you are studying, whether you apply or you not apply, is it going to be different? It's going to give you more information. So you are comparing NIRS and with and without the NIRS is your intervention. So your outcome is actually, what is your outcome, So what you want to demonstrate and could you reach there or not is what we are trying to ask you. You can go back and actually think about it when you design a next study, okay?
Thank you. Thank you, sir.
I'd also like to welcome Dr. Pranab Kumar De. He is the Associate Professor, Department of Pediatrics, RG Kar Medical College, Kolkata. He has had 12 years of teaching experience of undergraduate and postgraduates in different medical colleges. Welcome, sir. Now we'd like to proceed to the next original paper presentation by Dr. Sandeep Kumar. He is the Assistant Professor, Kasturba Medical College, Manipal, Karnataka. Please come and present your case.
Hello. So I can start. Good morning to one another. So just this, so I'm going to present this article. It's like a clinical profile and radiological features and outcome of children with viral pneumonia. Actually, okay, and then PSU was got admitted. So I'm from Manipal, KMC Manipal. So introduction. We'll go into the other. So as we know, pneumonia is the leading cause of for the mortality and then morbidity in especially under 5. And until now, it was the influenza and then RSV which we used to see. But now currently we are having much more viral outbreaks actually. Though majority of the viral infections, what we say, there will be benign and self-limiting, but the recent years we learned that they have been implicated in the much more, they cause much more morbidity as well as mortality. And hence, so we thought we'll see regarding this, what were the clinical outcome, and then this one we thought we'll see. So aims will include, so describe the etiological and clinical as well as the radiological and laboratory features and whether outcome, and what are the risk factors which are with the outcome they are, which are with the outcome we thought. So methods, it was only a retrospective only, it was a descriptive one. Mainly it was in those who were admitted in the PICO at our department. It was only for the 6 months actually. Actually we are continuing it, but we could not get that. And then we, the participants included the children from 1 month to 5 years of age. We included here because it is the viral infections which are more common in 1 to 5 years also, and the pneumonia word especially it will be from 1 to 5 years. So we restricted the age to 1 month to 5 years only. So we defined as per the WHO definition only. With that we has to have an presence of an abnormal chest X-ray and being confirmed by the RT-PCR assay. Those who were positive for the RT-PCR assay only we have included actually, and those children only whom the with thought of a viral pneumonia but the negative for RT-PCR we excluded them that actually. And also those who were coming with a bacterial infection outside with a positive culture also we excluded, and the study we got the approval also we got. So baseline demographic and laboratory data and all we had, and then also we use a press score we used here in order to differentiate between the how sick they are, how the respiratory distress and all, and antivirals whatever they use, and the supportive therapy and the length of the PSU stay and the outcome also we have defined. So results we included actually on that 6 months which we had 42 children with the probable viral pneumonia were admitted inside the PSU, out of which 28 children were only positive for this RT-PCR assay. So, and then the age was from the 2 months we had the youngest child, and 44 months was the older child, with the mean age of 20 plus 4 months period, and then the male to female ratio was equal almost 1:1. So etiological profile when we saw it, most common was, as we know, it is in influenza only, out of which H1N1 we had 8 cases, and in influenza B we had 5 cases, and H3N2 we had 1 case, and RSV we had 6 cases, and adenovirus we had 4 cases, and human Boca virus and 1 each of human rhinovirus and human metapneumovirus we had 1 of. And of the 14 we had those were 10 cases were occurred in the winter only we got. And the mean duration of the symptoms was 4.5 plus or minus 1.88 days with this thing. And fever, cough and respiratory distress was there in all of them, but only one child in addition had a croup-like symptom, and also 3 children with H1N1 presented with the gastrointestinal symptoms there, and 1 child with the influenza B pneumonia had a GTCS actually. And the press score when we had, we divided the 7 children had a mild respiratory distress, whereas the 7 children had moderate respiratory distress, and the 14 had with the severe respiratory distress. And hypoxia was seen in, saturation less than 90% was in 24 children we had. So here I have put in that table we can see almost, I want to tell the median duration of illness, if we see, it was much more prolonged in the adenovirus group when we saw, and the respiratory distress and the comorbidities we also encountered, which is very important. So malnutrition, 12 of them had, and 3 had 3 existing V's, and congenital heart was there in 3 actually. And then the neurological illness was there in 3, and cleft palate was there in 3. So laboratory features, if you see, it is the anemia which was there, and leukocytosis also, and CRP was there in 5, it was high, and hypoalbuminemia was there in 13. So I want to say, among the X-ray findings, I wanted to tell the most commonly which we saw was the interstitial opacities, and the upper one is the upper lobe consolidations.
Time is up.
Time up. Okay. So I wanted to briefly tell again the X-ray and then finish.
Okay, fine.
So it is this
So
thing,
this
and
was
the
a study
respiratory support.
over 6 months.
Yeah, 6 months only it was. And one more thing we had not included the COVID patients, because they were admitted as per the hospital policy actually in one more area like that. So they were not included. So the complications are. So conclusion what I put was the, so here is the, so we have to look for all the so comorbid illness which is important, and also they had like the one more thing was and the X-ray features of extensive X-ray features, and the SF ratio of less than 250 and all. And then those had a worst outcome actually. So here if you see, and also those who had a neutrophil lymphocyte ratio of more than 2, and also had a worst outcome.
So you cannot compare these patients because you have a lot of confounding factors. Like
Yeah,
you
is
have
there.
already
So
mentioned.
much is there.
If the child is having a comorbidity, then
Illness.
obviously the outcome will be different
Outcome
from
will be
those without comorbidity.
Yes. So anything else?
First, thank you. It's a good study we have done.
But
I want to mention something, that the sample size is very small.
Very small it is, only yes, because we thought
Lot of studies, it's not so good. You want we go.
Hello.
Hello. You want to show the features of viral pneumonia.
features.
Okay, mainly clinico-demographical study, I think so. So when you want to study, you have to do only one group, I think, RSV or adeno like this. When you want to exclude all these mixed bugs, I think it's very difficult to study in such a way, and because that you cannot compare
Yes.
the findings by lab findings and those you were showing by your study. There are so many bugs are there. So one is showing something, one is showing something. You cannot compare them, first of all. Then most of the studies showing RSV is very high percentage.
Yes, sir.
You are showing influenza.
Actually, influenza was
there is high. That is maybe, I think, a bias. And definition of viral pneumonia, I think it's not right.
Okay.
Just conclude. You want to say something?
Thank you, ma'am. Thank you, sir.